So we are looking forward to now inviting Alia Lilienstein. I'm really sorry for mispronouncing your name, but I was asking the other day. So Alia is a board-certified family medicine physician, which has greatly influenced her understanding of patients' struggles with the human conditions and the effects these struggles have on their loved ones. She has a BA from Georgetown University, and then she has a master's from Public Health and Epidemiology and Biostatistics from the University of California, Berkeley. And she also has worked in clinical research and development at Chiron. She received her medical degree from Mount Sinai College of Medicine in New York and has completed residence training at Cambridge Health Alliance, a Tufts and Harvard-affiliated accountable care organization. And she works for MAPS and has a certificate in psychedelic assisted therapies and research from CIIS in San Francisco. And I had to cut down these bios, but all of the bios are outstanding and all of you are just kind of rock stars. So I'm really excited about inviting you to the stage, and the floor is all yours.
Thank you so much. I'm really honored to be here today, speaking with all these other amazing thought leaders, and I'm going to be sharing a simple presentation with you. I'm sorry, Bia, I am using PowerPoint. I know that you really preferred that we didn't, but I'm a visual learner.
And some of us are too, so don't worry. This is fine.
So a little bit about myself. My name is Alia Lilienstein. I'm a family medicine physician and a public health researcher. I am medical director at MAPS Public Benefit Corporation. And similar to Monica, I also felt a need to share the other roles I have in life. These are not all of them, but I am a daughter, a sister, a friend, a wife, and a mother. And when I was thinking about why those things felt important, part of it is I feel like I'm working so close to things that I truly believe in that my roles as a medical director and public health researcher and family doctor, almost like being a wife and a mother. And also because I put my daughter down for her nap shortly before this talk, and she's sleeping in the room right next door to me. So life has become very intertwined and flowing in a beautiful way. And I have nothing to disclose in terms of financial or anything otherwise. This is a picture of my husband and me and my daughter on New Year's Day. So when I was in my medical training, I learned a valuable lesson that when I'm engaging with a project and with a diverse group of people and speaking to many different topics within that project, it's really important to find common ground in our interests and goals so we can unify our efforts and be each other's advocates. And this common ground brings humanity to the project and facilitates cooperation and flexibility around the details about how to achieve these goals of the projects that we're working on. Oh, I hear that the PowerPoint is not sharing.
Yeah, I just wrote to our tech support, so he should be able to get them on in a second. But when you said, here's a picture of my daughter and my husband, we all said, where? We can't see the picture. Yeah,
I'll go back once they're on.
We will want it.
Okay. I'll keep talking, and when they're on, I'll show you my daughter. So this common ground allows for us to harness our collective power. I'm going to try to screen share again. And the screen share icon is not showing up like it was before on the top of the image. Here we go. I'll try again. It says I am screen sharing. Is that working now?
Yes, it's looking great. Thank you.
Excellent.
And we can still see you there as well.
Yes. Well, okay. Here's my daughter on New Year's Day with my husband and me. Okay. So with the idea in mind of common ground, as I looked through the presentations and what people are going to be talking about today, two big themes came out to me, and those were the concepts of understanding and access. That is, understanding of and access to psychedelics. So what do I mean by understanding? Potential harms and risks, and benefits, but is that to the user of the drug or to society, to the environment, to the world? I mean, I think all of these things. Historical context, how has this drug been used in the past and currently? And is drug even the right word to call it? Drug, medicine, substance, molecule? And what do we want the future to look like? How do we want to use these drugs? Access, make it accessible to those who would benefit. It sounds so simple, but who decides this? How do we make sure that everyone's viewpoints are represented fairly? What does benefit look like or even mean? Is it pleasure? Is it reduction in disease symptoms? How do we measure and assess it? And really, what does access look like? And what is it? So these are really complex questions, and since I'm here representing the efforts of MAPS Public Benefit Corporation, I'll be focusing on MAPS, Public Benefit Corporation itself and its mission. So MPBC's mission stated is to catalyze healing and well-being through psychedelic drug development, therapist training programs, and sales of prescription psychedelics, prioritizing public benefit above profit. So one of the questions I asked myself is, how are understanding and access reflected in this mission and our efforts? When I look at the concept of psychedelic drug development and think about understanding, I think about how the drug affects the mind, psychologically, psychiatrically, and our daily function. The body, we're looking at physiology and physiologic safety. And the soul too, I think we're looking at through qualitative measures and having our participants share not just what we have decided in assessments to evaluate, but actually how their experience has impacted them. And in terms of access, we do have a goal of regulatory approval, medicalization as available as a prescription medicine. And we're doing that prioritizing benefits over profit, which improves access. When I look at our goal of therapist training program and think about understanding access in this context, we're thinking about and planning for therapists to be trained, and that contributes to understanding in terms of how therapists just support others during their experience of using these drugs, and providing structure and community for education of the therapists. And also access, making sure that there are enough therapists for all the people who might benefit for these drugs, and doing all of that while prioritizing benefit over profit. And then, yes, the sale of prescription psychedelics, which enhances access. Someone has to make the drug, and quality and availability are important. Unfortunately, MDMA is hard to make, and you can't just grow it in your garden. And prioritizing public benefit over profit is part of the mission in this sale. So some of you may be wondering, what is a public benefit corporation? And I have on the screen here something from our website, which I think describes things well. A public benefit corporation pays taxes, so it's not tax exempt like a nonprofit. It does operate for profit, but it spends those profits on a specific benefit that is listed in the mission. And it's obligated to be transparent with the progress towards that mission and those goals. It can have shareholders and stockholders. And for the purposes of MAPS Public Benefit Corporation, there is one shareholder, which is MAPS, the nonprofit. So this answers kind of the question of what is MPBC and how are we moving towards understanding and access. But who is MPBC? I feel a corporation is an entity that is a group of people. And in this case, a group of people, relatively like-minded people working on the shared goal of increasing understanding of and access to psychedelics with expertise and interest in drug development as one method to attain these goals. And because of this, I feel the need to really share with you who are the people in MPBC and why are they doing their work. Each of us as individuals in a corporation have their own motivations, and I want to share with you some of those motivations. So this is most of us at MPBC from a retreat back in 2018. I was on maternity leave at the time, so I'm not there, and we have grown in the last 2 years. But you get an idea. We're not a big crew in the grand scheme of things. So here's the first perspective I'd like to share. I am going to read people's quotes that they gave to me. I asked people to share with me why they work for MPBC, what motivates them, so that you could get from their own words why this work reflects their goals and interests. So this is from Melissa Field, who's a clinical trial leader for MPBC. I come from a community and family where a stigma was always placed on mental health and inclusiveness. It was hard and heartbreaking. As an adult, I made a conscious decision to be better for myself and my own family, including seeking treatment for my own mental health, being open with my children about it, and teaching my children to be inclusive always. I have a commitment to myself to be better and to break negative generational cycles. MPBC is a family aligned with my own benefits, and we have a joint effort to help people find healing they deserve. This is what continues to motivate me every day by working at MPBC and being part of this mission. This is from Shannon Claire Carlin, who's our Director of Training and Supervision. These are the reasons she works for MPBC. Dedication to acknowledge and transform suffering, my own and others, care for fellow humans, co-creating our collective reality, uncovering and celebrating the depths of human experience and our incredible ability to heal, cultivating the tools and resources available for healing and growth, honoring sacred medicines, immense gratitude for the growing availability of healing technologies through nature and science, desire to be of service. This is from Charlotte Harrison, our clinical program manager. MAPS is working at the intersection of cognitive liberty and society's need for innovative treatments for mental health conditions, reason and compassion. This is from Corinne DeBoer, our senior medical director and head of safety. For me personally, the potential promises that psychedelics can provide in the treatment of PTSD and other indications is an exciting scientific field and one where there is a high unmet medical need. This is from one of our non-clinical interns, Lakin Barber. I love working for MAPS because I feel like I'm making a difference in the world. PTSD is a topic that is often seen as taboo, and MAPS is actively working towards new treatments and normalizing the topic. The people I'm closest to, including myself, suffer from PTSD. I feel incredibly honored to be part of the solution and something greater than myself. All of the people I've worked with at MAPS are truly amazing and driven to make the world a better place, and I couldn't be more proud to say I work for MAPS. This is from an anonymous person in our organization. As a woman of color with a family member who has PTSD, it is very obvious to me why MDMA-assisted psychotherapy would be great for my community and all communities. The enrollment of minority participants and the unique types of psychopathology in the minority population does not seem to be an area of focus in psychedelic-assisted psychotherapy in recent years. But I feel like MPBC is making efforts to address this fact in a variety of ways. Therapist of color training program, assistance to certain phase 3 sites to recruit participants of color, etc. Although there's still much more to be done to ensure that this population is not forgotten in this work, I believe that MPBC is trying. I have a couple more. Thanks for listening. This was from another anonymous person at our corporation. I grew up in a household where one of the family members suffered from unprocessed and inadequately treated trauma, causing depression and addiction. These illnesses ultimately took their life and left a deep wound in my family and me. As I grew up having an Indigenous background myself, I had the opportunity to process what had happened by learning from Indigenous people that have a different healing approach than Western medicine. With the support of a diverse group, I was taught to heal myself and thrive. Luckily, I was also aware of the research done by Dr. Albert Hoffman, Dr. Stan Groff, and Dr. Alexander and Ann Shulgin. I was able to integrate the teachings from the Indigenous communities with the research that had been done decades before and used it to keep working on my healing process. I work at MAPS because I believe that by continuing the research of psychedelic medicines while preserving the cross-generational knowledge of Indigenous communities, we have the opportunity to improve mental health and quality of life, save lives, and keep families together. This one's from Amy Emerson, our Executive Director and Head of Clinical Development and Regulatory Affairs. And Amy will be joining me in the question answer period after this. She says, I do this work because I believe in the value and need for these new tools in mental health. And we also all have the right of cognitive liberty. And I felt like I should share mine too. So I am passionate about helping develop better tools for psychological exploration and healing so that everyone may have the opportunity to approach themselves and others with empathy and love. So as you see, that there wasn't a lot of mention of developing drugs or commercialization or medicalization in the heart of why people work. But I think drug development is a form of psychedelic liberty, and people see it that way. And so I think the key to understanding that is looking at the goals of understanding and access, and where are its constraints, and how does drug development address them, the understanding and access and the constraints. So to step back, I think it's important to really think about what is FDA approval or regulatory approval in other countries. And really, it's a permission to market a drug under a specific claim for an indication. What that means is that it can be marketed to prescribers and to patients. And specifically, that's, an example is like drug X has been shown to effectively treat disease Y. So it is a marketing claim. And I think it's important to recognize that. But how does it contribute to understanding? It helps us understand credible drug information to allow us to have a better conversation about risks and benefits. It educates medical providers who will write the prescriptions if we're going in a medicalization model. It allows for informed decision-making for prescriber and patient. And this is something that I think is especially important, and something that's a great benefit from the drug development process is we do get a lot of information about how a drug affects someone physiologically so that people can make good decisions for themselves about whether those risks are worth it to them. And we can help potentially mitigate those risks and reduce them so that they're less likely to happen. I do think the major constraint is that we get this understanding from the context of the clinical trials, and so we're limited by what we measure and what we see, and the clinical trial method of structuring things in general, which does not inherently support a qualitative experience, since we have to measure things. In terms of access, then drug development allows medical providers to prescribe the medication, which is a step in the right direction, perhaps, of access, or maybe not to some people, but it does allow for a different kind of access than what currently is available. And it certainly does not necessarily mean legalization. But one of the big questions that comes to me regarding this is how do we ensure that everyone who would benefit from it has access, even in a medical model? If you're interested in reading more about psychedelic drug development, Dr. Victoria Hale wrote a really good piece in the latest MAPS bulletin that I definitely recommend you read that goes a little bit more into this and how regulatory works with the psychedelic world to make these medicines available and understand them better. So I want to speak a little bit to the MDMA clinical trials that MAPS is doing, because I think it's important information that you guys are going to want to hear about as well. We're doing MDMA clinical trials in the context of MDMA-Assisted Psychotherapy, largely for PTSD. What this means is that the drug is administered during an 8-hour therapy session, and the person taking the drug is accompanied by 2 trained therapists. It is a controlled clinical setting, which sounds worse than it is. Generally a nice living room with a calm, peaceful atmosphere, not really what you probably typically think of in a clinical setting, certainly not a typical doctor's office. It's a supportive environment. And then people have 2 to 3 of these sessions in the setting with the therapist about 1 month apart. And these sessions, while they're 8 hours long, are also accompanied with a significant amount of other psychotherapy before, in between the sessions, and afterwards to really help the medicine and those experiences catalyze growth and development. And we do this in a double-blind, placebo-controlled fashion so that we can produce rigorous data for the FDA. So I'm going to give you a little bit of information about the data from our phase 2 studies. We've concluded our phase 2 studies. That's obviously before phase 3, which is the last phase before approval, if you're not familiar with that. And so this is our data from the last set of trials that have all finished, and what we presented to the FDA to be able to move on. So these are, again, for MDMA-assisted psychotherapy for treatment of PTSD. And so what these studies have shown is, and what I'm showing here is a response to treatment, which means a clinically significant reduction in PTSD symptoms, and it was measured about 1 to 2 months after the last treatment session. So people who had MDMA with that 42 hours of psychotherapy, 78% of those people had a response to treatment and reduction in their PTSD symptoms. People who received placebo, then that 42 hours of psychotherapy, had a 42% of them had a response to treatment, a reduction in their PTSD symptoms. So you see, alone, the psychotherapy does appear to be really helpful. Then if we look at remission of PTSD symptoms, that means they no longer meet PTSD criteria assessed by a clinically administered PTSD scale. And again, this is 1 to 2 months after the last treatment session. In the MDMA group, that's again, MDMA plus 42 hours of psychotherapy, 53% of people had complete remission, no longer had symptoms meeting PTSD criteria, and 19% of people in the placebo group. And then we looked at long-term, the durability of remission, that is 12 plus months after the last active dose, what percentage of participants had a remission in their PTSD symptoms, and that was 67% of participants. And this includes participants who initially got placebo. That's because after they had their placebo journey through the psychotherapy, and we got that data that showed that the MDMA group was so much better in terms of response, we ethically switched them over to give them an opportunity to have MDMA-assisted psychotherapy. So they're all included in this group. It's important when we're talking about how well things work to also talk about the risks and safety, so that we understand that everything has a risk-benefit ratio that we're constantly thinking about. So there is a cardiovascular risk for MDMA. There are short increases in heart rate and blood pressure, which, depending on your baseline cardiovascular risk, could be minor or could be more significant. Some people experience psychological distress in the therapy sessions, or typically is self-limiting. Some people have an increase in suicidal ideation, but again, we're working with a population that has a higher incidence of suicidal ideation given they have PTSD. And we mitigate any potential for abuse because the MDMA is just administered in the therapy session. If no one goes home with any MDMA, and we haven't had any evidence of neurocognitive impairment in our phase 2 trials. So based on this data and from phase 2, MDMA received breakthrough therapy designation in August of 2017. That means the studies demonstrated a meaningful advantage and greater compliance over other available PTSD medications. And it means that we receive additional guidance and expedited review from the FDA for our studies to help build our case for approval of MDMA-assisted psychotherapy for treatment of PTSD. Our next steps are we have phase 3 studies underway, and we have other supporting studies to better understand MDMA safety profile. And all of this stuff hopefully will get us closer to approval in the next couple of years. I give a vague description of when because COVID-19 has definitely changed things a little bit. Which is something I wanted to address as well, especially since we're all at our homes, perhaps in our pajamas or non-professional attire because we're not together in a in a location, in conversation, and face to face. But COVID-19 has caused some delays in our efforts. But the plan is to proceed as we design safe ways of continuing our studies. That includes making more of the therapy remote and making sure we're doing everything we can to understand people's individual risks. Certainly as more information becomes available and from the scientific world about the COVID-19. But COVID-19 is touching everyone, and it's clear that there's a global need for novel, effective ways of healing trauma for the people who suffer from the disease, for the healthcare workers, for all of us who are at home, for people who have to work, everyone. And I think understanding is vital to help provide that safe access in the future. It's part of our obligation, as Bia talked about it. When comes freedom, there also comes obligation. I think understanding as an obligation so that we can freely use psychedelics as our society chooses to. And that's it. Thank you so much.
Thank you. That was really excellent. We've had a really active chat happening about all of the things that you've been mentioning about how do you do. I'm just going to throw it out there before I bring on Amy. What is the placebo that is used?
So we've used different placebos in different studies. We've tried very low dose MDMA, and now we use a sugar molecule called mannitol, which is a totally inert placebo. So it is essentially taking a sugar pill.
Because people were asking, how can you placebo MDMA? Because there's such a clear feeling that one gets.
Yeah, it's really hard. I think part of it is really understanding the powerful influence of set and setting. When you're in a room with two therapists and you've had a lot of therapy to get you there, and there's music playing and you're in a calm environment and you have eye shades on and you're listening to music, things still come up, whether you're on MDMA or not on MDMA. And sometimes it's hard to tell. But you're right, it's difficult to blind people. But some people have been fooled before. Well,
and I mean, yeah, I always just love seeing the results of these studies, because it's where you actually, if anyone was coming out with these results with other types of medication, they would have fast tracked these to be on the market, you know, and it's because of this historical stigma that we have against some of these, that it has been so slow to move. So I'm going to welcome Amy, and she probably doesn't need an introduction, but I'm going to do a short one anyway. Amy Emerson is the Executive Director and Head of Clinical Development and Regulatory Affairs at the MAPS Public Benefit Corporation. That was just very well explained to us. Amy leads the growth and development and is responsible for overall global regulatory strategy and implementation of research programs with a focus on the MDMA-Assisted Psychotherapy program, which clearly also has a focus on PTSD. She began working with MAPS in 2003 as a pro bono consultant, and she brings decades of pharmaceutical development and research experience in phase 1 through phase 3 randomized controlled trials. So thank you so much for joining us, Amy. Oh yeah, somebody just mentioned we're all wearing red.
I know, we coordinated, right?
We did not plan this, but
no,
it's very nice. Somebody should take a picture of us, and then. So thank you, Amy, for joining us. Amy is here just for the question and the answers, and so I want to jump in to the questions that have been coming out, because we already have quite a few.
I actually wanted to, I jumped in even a little bit, because I wanted to say something about the placebo.
Yeah, great.
Since I can see over here, it's a hot topic. So one of there's multiple ways to work on a study where you can have a blinded, do blinding, and one is observer blinding. So though we have a control group, that's not truly a placebo because they are receiving a treatment. So it's MDMA, assisted psychotherapy, and then placebo with psychotherapy. So it's very different from most studies in that one group receives absolutely nothing. So that's different in our studies. Psychedelics are very hard to blind, but one of the ways that we deal with blinding is by having the primary endpoints are measured by a blinded independent rater group that's never in the room during a treatment. So they're the ones administering the caps, and they rarely ever talk to even the same patient twice. So they see an independent rater for their baseline, then they see an independent rater at various times during the study to have their caps measured again, and that rater knows nothing about what happened to them during their treatment. So that's a really important part of blinding. You can't do that with a self-report measure, obviously. So another way that we strengthen our studies is by using a report, like a measure that's not self-report. It's a semi-structured interview. So I just wanted to throw that in there to help explain the placebo part a bit more.
Yeah, it seemed to get a lot of. So the top question, and I think, we can go through a lot of these, because a lot of the questions that have also been coming out is, how is this? There's just so much interest in being part of the work that you all are doing. In being a therapist, in maybe not having that background. That's the first question that we have, from someone who is graduating college and looking at master's programs in counseling. What's the route that person should take to streamline themselves into a career, but not necessarily have to pursue a PhD or a PsyD in psychology? And if that exists. And then the next question is how are you scaling therapist training? So if you can talk about how that kind of recruiting cohorts happen, and how do we, and Dr. Monica brought this up earlier, and you guys, mentioned it, how are we really improving people of color being part of those cohorts as well?
Mm-hmm. Alia, I don't know if you want to say anything about how people can get involved first. I want to make sure that if you have thoughts on that.
Sure. I think if this is your eventual goal to be involved in this work as a therapist, I think you should pursue whatever degree, training, counseling that you would have for any other kind of therapy, because at this point there isn't a academic track to do psychedelic medicine. And I think that there will be eventually a credentialing board and an academic group that comes together to help with reciprocity from other fields and ensure that there's good training specifically for this work. But we're still early in that process, and the therapists in our studies are from a variety of mental health backgrounds. So there's not just one. You certainly don't have to be a PhD or a psychiatrist.
Yeah, we're working with the FDA right now to try and continue to push back on what the credentialing requirements will be for the co-therapist and the lead therapist. So we don't know what it will be yet, but there's ways to become involved in this area that are not just related to therapy. So my whole team really is a team of people that are not therapists. There's our training group has that background. But if you're interested in research, then there's the clinical research aspects also. But most people, I think, when they're asking that question, they are asking about how to get involved with becoming part of the therapy. So.
I mean, there's been a lot of questions on this, on could there be something that is not as that many of the programs to become part of this can be costly, and so how do people get into those spaces when they're more selective? And then we even have questions from people as someone later in life wanting to be part of this, how do I get involved? No, and the CIIS training is coming up. Whether that might be something that you guys want to speak to. I mean, this is the main questions are really about how can psychedelic therapist training programs become more diverse and accessible to actors around the globe? People want to be part of this, but maybe some of us have already gone through our educational piece of our life. So how does one enter then? No, and without having maybe $10,000 or more to be able to get involved.
Yeah, I think mental health training is unfortunately really expensive in our society, and I don't think it should be. But I've watched a lot of friends who are becoming therapists in one way or another have to work, significant amount of hours to get supervision at very low pay to be able to even get their license. And so this is a deeper, bigger question than just psychedelic medicine. How do we train more people in supporting each other in general? globally, especially as we recognize the need for more empathy and support, and not necessarily in a degree granting fashion, but how do we make sure that there are people out there who know how to sit with other people through their processes?
Well, and this is something that comes up because so much of this work has happened previously without that containment spaces. And that's where then you have sometimes, I want to use the right words so this comes out, but like sometimes people take advantage of certain situations, and we hear these. I mean, this is something that comes up a lot in these psychedelic spaces where ceremonies have been the main source of being able to receive plant medicine or MDMA. And then how does that really, now it's shifting, no? And so now there's this new route, both to receive, but also to be part of it and to be able to hold that space for folks. And unfortunately, there hasn't been that many, there just aren't that many opportunities to participate, because this isn't, I think what's important, and you guys are showing, is it's not happening on a community level yet. You know, this is not broad spread. This is a very small subsection that are having the opportunity to work in this space.
It's pretty hard to make things broad when it's not legal yet, right? So you're taking a big risk if you pay for training at these points, or for people to develop training programs, when you don't know at what point you're going to be able to do it, right? You can't use the skills, you can't use a certification outside of a study for the most part yet. In ketamine you can, right? But so it's going to grow as the field grows, and as the first molecules make their way through an approval process, or even through decriminalization efforts, as things become, the ability to treat people grows, as that field grows, the training programs will grow. Right now, I know there's not a lot, and I do think that the training programs are priced pretty competitively. Unfortunately, it's still a lot. We try to, in looking at how we're pricing the MAPS programs, really cut it down to mostly the costs of the locations and our time. We really try to put public benefit before any type of making of money for all of the programs that we're working on. So it just is costly to do these things, but it's actually quite a bit shorter and quite a bit less expensive than many other certifications that mental health practitioners go through. So I would say there's also learning different somatic techniques. You can go and learn that, and you're learning how to hold space and work with people in those areas, breath work training. So there's other ways to get training that's very complementary. And we look at all of those things when we're looking at people coming into the training program, like what other types of background do they have? What other non-ordinary states do they have experience with, or experience holding space in, including breath work in that, or in somatic experience type work. So it will grow though, right? When there's a bigger field and there's more availability to treat people, there's going to be more people that want to provide training, and then that will be competitive, I hope, and that will create a marketplace that's more accessible to people.
Well, and it will improve just that it's much more broad spread when these legal barriers are brought down, and that's we know that, and we know that that's the main goal. There's
a lot of work to do across all of this, and I think one of the mistakes is, don't look at just the leaders that are doing the work right now, and then criticize that. Well, why are you doing it that way, or why are you picking the regulated way, or why are you doing it this way? Right? That there's so much work to be done, and we can all support each other in these different pathways. And so, if there's a way that you believe this should be working, or there's a way that you believe it should be accessible, go work on it. You will get support from this larger community. Like, we're just doing one thing. We have one type of training, and we have a medicalization pathway, and then MAPS does a lot of other educational work and tries to create more space for other pathways. But in the MPBC group, really, we are working on clinical trials. It takes all the bandwidth that we have just to do that part of it. But we welcome and support people doing this work in other ways too. I just want to make that really, that's really clear for people.
Yeah, no, I think that's a great point. We're going to take the last question, because it's just like these sessions, they're very short. So here's the question. What can cultural change makers and educators do to preemptively make scaffolding for information and education in place to make sure the public has a good framing on this issue. So it's really about like, how do we lay the groundwork for when some of these legal changes happen that then, society is ready for it? What are some of the risk reduction tools that should be in place if decrim were to go forward, in order not to get some sort of backlash? No?
That's a big question for a last few minutes. Relating it back to what we're doing, and certainly as a physician, I like to know what the risks are, so that I can then help understand what kind of scaffolding and education we need. And the drug development process does help us understand a significant amount what those risks are. And as I mentioned earlier, what are the risks to the body? What are the risks to the mind? How can we mitigate those risks, so that someone who maybe has a medical condition that might be riskier with MDMA, reduce that risk? So there's that aspect of it that I think is really helpful and powerful. In my community, I serve as that sort of medical expert for my friends in a sort of risk reduction ideology. How can I pursue this safely? And I think that's a really important part of the information that we're providing for people.
I like what somebody said this morning, benefit maximization instead of just risk reduction also. Mm-hmm. Right? Yeah.
Yeah, and because really this work is so much about bringing people to the place they want to be, right? Because folks are looking to change their experience of how they're feeling life. And there were some questions about, different levels of PTSD. If we had more time, we would be able to go into that and like whether some are easier to treat than others. But I just think, the work that's being done is really, and we saw it in the presentation, that the people were at the center. The heart is really the people that are both doing the work are there for a purpose, and the people who are there receiving it are there because they want to change how they're envisioning themselves and their own sets, and settings. So I just want to say
something really quick about the levels of PTSD. Like we work with severe PTSD, and for the most part, a lot of the people in our studies, it's extreme PTSD. Okay. But what the indication that we're going through is with FDA is PTSD in general. We're not going for treatment-resistant PTSD or only severe. And in our second phase 3, we'll go for like a high moderate. But when we do expanded access, which did get approved, which also is going to help open up things for more accessibility once we're through whatever it takes to get through the COVID and social distancing where it's safe to start those studies. We really are expanding out to a different group of clinics, and hopefully those clinics, then their job is to reach out to other patient populations that they feel that they can serve best. And we won't be looking at just severe PTSD. And there's also, we have to wait for, people have to have had the symptoms for 6 months to be in the study, but really the closer in time that you can treat PTSD to the trauma, the better. And then there's also accumulated life trauma, right? At some point, we want to get to that. And that's part of our impetus for going for PTSD in general, is it will be up to the treating therapist to determine the level of PTSD. And we really hope, now I don't know this for sure until we get a label, but there won't be a cutoff for the level of PTSD that's required for a therapist to decide to treat somebody. So I hope that's helpful.
That's very helpful. That would be amazing. It would just increase access substantially and allow for folks to really be, to have their needs
and
met.
bring it to the people who need it the most right now, possibly.
Yeah. And that's because there's certain communities that really have that ingrained trauma. And then there are those who have had an experience. And I think that's, a great point that you made, Amy, and Alia also. Yeah. Wow. Okay. So I'm getting messages that it's time to wrap up. I wish that, we're all I can hear the claps right here. They're all happening in the chat. Thank you so much for all the amazing work that you're doing. Folks around the world here are saying, can you bring this program to Mexico, to all these different countries where it's very much needed. And so thank you for breaking ground so that we can really make this as accessible as possible to all the folks that need it. So thank you so much, ladies. And we look forward to seeing ourselves physically once this is all this is all over. So thanks a lot. And I
Thank
feel
you,
amazing being
Zara.
on an all female panel, all, children that
I know,
are all
I'm sorry,
here
that was
around.
me with the
No,
children in the background.
somebody said it was great. And the thing is, my son could run it at any point. These things are going to happen. This is, as you said so well, our lives are mixing. There is no longer a work and then life. It's all together, and there's beauty and chaos in it. So
I just really appreciate all the incredible support I keep seeing kind of going through the side here. And Zara, you also, and just thanks to all the people that are taking their time on a Saturday to listen to the Psychedelic Liberty Summit. And thank you to Bia and Charkuna for putting this together.
Yeah, thank you all.
Thank you so much.
And Erin, our tech person, who's keeping us going on time. Thank you, ladies. Bye.
All right.
How are we all doing? Yes, women in red shirts. That's the new hashtag.